Stephanie Huff, and I'm recording another concept on cellular regulation. This one also goes along with your perfusion lecture. This one is on sickle cell disease. So an overview of sickle cell disease. It is a hereditary hemoglobinopathy, which is a type of disorder characterized by normal hemoglobin that is replaced with an abnormal hemoglobin S in the red blood cells. Your sickle cell anemia is a chronic hemolytic anemia. It is your most common type of sickle cell disease. Looking at the pathophysiology, your normal hemoglobin is replaced with abnormal hemoglobin S. And the red blood cells that contain the hemoglobin S will pass through blood vessels. The deoxygenated of the hemoglobin S causes red blood cells to become rigid and deformed. As a result, the red blood cells become a crescent or sickled shape. The sickled red blood cells will occlude small blood vessels due to the rigid red blood cells that are not as flexible as your normal blood cells. These are very rigid and inflexible. So your vascular occlusion can cause ischemia and organ damage. Repeated or prolonged ischemia causes this organ and tissue damage. Kids often will have a splenectomy in early childhood due to blood trapping in the spleen. Once you take out their spleen, then they're going to be increased risk for infections. The sickling process of the red blood cells is triggered by anything that increases the body's need for oxygen, such as fever, emotional or physical stress, high altitudes, poorly pressurized airplanes, hypoventilation, vasoconstriction from cold temperatures. Dehydration will also put them in a crisis. Trauma and infection. A sickle cell crisis is also known as a vaso-occlusive crisis, and this is when they have painful periods from ischemia due to vascular occlusions. Alright, and so this is a picture showing you normal red blood cells and their shape versus somebody that has sickle cell anemia. And so you can see how they are in more of a S shape, and so they're just kind of curved, and so they just call it hemoglobin S. And so they're just that curved sickle cells, and so you can see how they can clump together. If they're very rigid, then they can actually occlude some of those smaller vessels. Alright, etiology. Sickle cell anemia is transmitted as an autosomal recessive genetic defect. The risk of having a child with sickle cell disease is 25% if both parents have the trait. There are clusters of deoxygenated hemoglobin S that deforms the erythrocytes into crescent sickle shapes. When hypovolemia develops, the hemoglobin S is deoxygenated. It will crystallize into rod-like structures which tend to clump together. This obstructs blood flow, and it causes ischemia and possible infarction of the surrounding tissues. Alright, so this is showing you kind of the breakdown. So if somebody has the trait, then they do not have the active sickle cell anemia, and they don't usually go into any type of crisis. They are usually completely asymptomatic. So if you've got a normal mother who doesn't have a trait or the disease, and the father just has the trait, then you can see half their kids will have a trait and half will be normal. If you've got a father with sickle cell anemia and the mother's normal, then you have all of your kids will have the trait. If both have the trait, then you will have half that have the trait 25% will have sickle cell disease, and 25% will be normal. If the father has sickle cell anemia and the mother has the trait, half will have the trait and half will have the disease. And then if both parents have sickle cell anemia, all of their kids will have sickle cell anemia. Alright, so risk factors for development of sickle cell anemia. Most common is among African descent. Carriers of 2 hemoglobin S genes have sickle cell disease. Carriers of 1 hemoglobin S genes will have sickle cell trait, and that's kind of like the pictures that I just showed you. They're usually asymptomatic, but at risk for a sickle cell disease if stressed by severe hypoxia. But like I said, that's really rare. Alright, your clinical manifestations. They can have acute and chronic manifestations, and these come from episodes of red blood cell sickling. General symptoms of hemolytic anemia are pallor, fatigue, jaundice, and irritability. People that have sickle cell anemia will have a significant risk of having or developing a stroke. Some of your other complications will be an enlarged spleen and liver, renal insufficiency. They are prone to gallstones, priapism, which is a painful prolonged erection, may have abdominal pain, and that may signal an infarction of abdominal organs and structures. They may also have an aplastic crisis or temperature, a temporary cessation of bone marrow blood cell production. Your sickle cell crisis are painful episodes that result from ischemia, like we talked about. They can last an average of 4 to 6 days. Extensive sickling can precipitate a crisis. Pain, you want to ask about the intensity of it, duration. Often this depends on the patient and the location of the pain. It can be a generalized pain or a local pain, like to a wrist, knee, or back. They may also need opioids and PCA pumps, which is your patient-controlled analgesic. They have shortened red blood lifespans. Compromised erythropoiesis can lead to profound aplastic anemia. So depending on the type of etiology, what's going on, it will depend on your symptoms. And so your vaso-occlusion or your thrombotic cause, they are going to have, this is your most common type of crisis that we were just talking about, can last for days to weeks. It's usually precipitated by dehydration, exposure to cold, acidosis, or localized hypoxia. It can also be caused by stasis of blood with clumping of cells in the microcirculation with ischemia and infarction. They can have thrombosis and infarction of local tissue if the crisis is not reversed. The cerebral occlusion can result in a stroke. This is manifested by paralysis or other central nervous system complications. These type crises are extremely painful. Symptoms may include fever, tissue engorgement, painful swelling of joints in hands and feet, priapism, and severe abdominal pain. Your splenic sequestration as being a cause. This is a life-threatening crisis. Death can occur within hours. This is caused by pooling of the blood in the spleen, and because the spleen can hold much of the body's blood supply, cardiovascular collapse can occur, most commonly seen in kids and adolescents, but may be seen in young adults as well. Your clinical manifestations include profound anemia, hypovolemia, and shock. If aplastic crisis is the cause, this is diminished production of increased destruction of red blood cells. It is often triggered by human papillomavirus B19 viral infection. Signs include profound anemia, pallor, and fatigue. In acute chest syndrome, this is a common cause of hospitalization for sickle cell disease, associated with a pediatric mortality rate of 2% and an adult mortality rate of 4%. They will have pulmonary infiltrate of abnormal blood cells that leads to lower respiratory tract symptoms. Manifestations will include fever, cough, chest and back pain, dyspnea, and hypoxemia. They may have pulmonary infection, infarct, and fat embolism can occur and lead to pulmonary death and failure. All right, so your lifespan considerations. For your pediatric clients, they may be asymptomatic until 4 to 6 months. Most that just have sickle cell trait never have a crisis. Pediatric clients are at risk for acute chest syndrome, which we just talked about, chest tightness and shortness of breath. They're at high risk of having a stroke, so 10% will develop strokes. Your pregnant clients usually have more frequent pain crises, along with more intense symptoms. They have a higher risk of complications such as miscarriage, premature birth, and low birth weight. Collaboration. For optimal care, they are going to need neonatal screenings, early interventions when they're having complications or they're in a crisis. They may be put on prophylactic antibiotics. Education of the parents about the disease so the kids with sickle cell disease can live into adulthood. The better their disease controlled, the better their long-term outcome. Alright, diagnostic test. Amniocentesis can be done, but most of the diagnoses are made after the delivery by testing the newborn's blood with a heel stick. That is a mandatory newborn screening now to test for sickle cell disease. Routine ultrasound starting at the age of 2 years for signs of stroke. And the ultrasound is done of their head, and they're assessing the cerebral blood flow. And that's just because they have a lot of cartilage and their skulls have not completely fused and have gotten really strong yet, since they are still growing. Alright, surgeries. They can do a bone marrow or stem cell transplantation, splenectomy for life-threatening splenic red blood cell sequestration can be done. Your pharmacologic therapy. Anytime somebody comes in with a crisis, oxygen is going to be one of the important things to do, and that will help decrease the risk of hypoxemia and associated complications. It also helps to minimize their dyspnea. Hydration is another important factor, and that will help promote pain relief, reduce the blood viscosity, and help rehydrate them. Analgesic administration is your other important factor. Morphine is usually given IV as needed or via a patient-controlled analgesic pump or your PCA pump. Hydroxyurea is used in both adults and children. It is a cytotoxic medication. It decreases the production of abnormal blood cells and leads to a lesser amount of pain. It also increases fetal hemoglobin production. Side effects are bone marrow suppression, headache, dizziness, and nausea and vomiting. Prophylactic antibiotics are used for kids 2 months to 5 years old with a diagnosis of sickle cell disease. Usually they are treated with prophylactic antibiotics daily, and they use penicillin for this. If the kids have had a splenectomy, they will have a decreased ability to fight infections because your spleen is your major organ of your lymphatic system. So if an infection is suspected, then they culture the blood, urine, and throat. So they're basically just trying to culture everything they can, and they will need aggressive antibiotic therapy. Vaccinations, including the flu vaccine, are going to be important to help decrease the risk of infections, since they are prone to infections. Your non-pharmacologic therapy. Blood transfusions are a core component of treatment. Benefits include improved blood and tissue oxygenation, reduction in sickling, and a temporary suppression of red blood cells with the hemoglobin S. Chronic transfusions are also good treatment for stroke complications. Some of your complications, they are going to be at risk for iron overload, which is called hemosiderosis, and that's from lots of blood transfusions. And the body is not able to excrete iron very well normally. So they often will have to give an iron chelating drug like deferoxamine, and that's given with vitamin C to help promote iron excretion. And so that will actually help break down that iron and help it to be excreted. They're also at risk for alloimmunization, and so that occurs, and that's from due to red cells and platelet antigens, and this occurs when the kid's immune system reacts against antigens on a donated tissue, and that would be from like blood and stem cells. Alright, so complementary and alternative therapy. Massage is good at effectively reducing pain. Studies are evaluating the effects of nutritional supplements on the inflammatory process that's associated with sickle cell disease. So your acetyl L-carnitine or your alpha lipoic acids, they work on inflammatory processes in patients with sickle cell disease. So looking at the nursing process, a comprehensive physical assessment is essential because any body system can be affected. You're focusing on providing care and teaching to the client and family on how to reduce sickling, provide home care, and report symptoms immediately. So for your assessment, you want to get a detailed history about their past crises, their precipitating events, medical treatment, and home management, assessing their pain level using a pain scale. Emergency conditions, these will include fever, neurologic changes, such as decreased alertness, behavioral changes, respiratory symptoms. All of these will require prompt treatment. So you want to monitor your patients that are in sickle cell crisis, because they can deteriorate and develop shock, and that will cause low blood pressure, so hypotension, changes in their level of consciousness, dizziness, lightheadedness, increased capillary refill time. Your psychosocial assessment. Sickle cell disease does interfere with self-concept, level of independent functioning, and ADLs. They may have guilt because they have this disease and others are having to care for them. They may feel depressed or even isolated. The family may need assistance with dealing with feelings related to this serious disease. These are your NANDA diagnoses for sickle cell disease. Alright, in planning, some of your goals may include patient oxygen saturation will be greater than 90%. Their respiration rate will be between 12 and 20 breaths per minute at rest and with appropriate activity. They will deny shortness of breath and dyspnea at rest and with appropriate activity. They will deny manifestations of acute chest syndrome, chest pain, adventitious breath sounds, pulmonary infiltrates, increased white blood cells. They will demonstrate no signs of a stroke. They will also demonstrate a urine output of at least 0.5 milliliters per kilogram per hour. They will demonstrate no signs or symptoms of infection. They will consistently rate their pain at a level of 3 or less in adults and a tolerable or absent level for children. And so on the kids, a lot of times you have to use the faces, but if they are young enough where you can't use the faces, you have to go by like facial grimacing, crying, guarding, those kinds of things. They should meet criteria, both height and weight, for normal growth and development. Implementation, nursing management may include promoting optimal oxygenation and circulation through administering blood transfusion and oxygen as ordered, monitoring for transfusion reactions, encouraging the client to balance their activity and rest. They may need help planning activities to help them get activities that are better suited for them. Also scheduling caregiver activities and play to allow for optimal rest. So sometimes they can get other people to come in and stay with the patient if needed so they can get out and have some time by themselves. Maintaining fluid volume balance is done through administer IV fluids as ordered, because dehydration can lead to life-threatening consequences, so you want to make sure they are good and hydrated. Adjust their oral intake to keep them well hydrated. Calculating their fluid balance requirements, and this is based on the minimum fluid intake that is necessary to maintain hydration. You also want to monitor oral and IV intake, teaching the client and parents how to monitor their intake and output to make sure that they're staying well hydrated. Managing pain. This is done through administering their prescribed analgesics around the clock during a crisis. Your client-controlled analgesic is also your PCA, your patient-controlled analgesic. You want to provide education for the parent and the child about bolus infusions as needed. You also want to make sure that the PCA pump is running constantly as ordered and prescribing and the correct amount of medication. You want to reposition them for comfort, supporting their joints and extremities on pillows or the use of a special mattress. Do not use hot or cold compresses that can further cause tissue damage and pain. Preventing and managing infection. Infections will make the patient more susceptible to a crisis, and then once somebody's in a crisis, that will increase their susceptibility to infection. So it's kind of like this vicious cycle. So you want to teach parents how to administer antibiotics for prophylaxis or treatment, assessing the resources like finances and other resources to obtain and administer the antibiotics. Encourage the use of vaccines, like your pneumococcal vaccine is given to all infants and children. Your HIB is HIV vaccine, which is an influenza type B vaccine. This is started at 2 months of age and it's continued at a recommended ages to prevent another common source of infection, which is flu. Facilitating normal growth and development, encouraging the importance of nutrition and hydration to promote growth, encouraging high protein, high calorie diets. You want to emphasize importance of folic acid and vitamin C supplements as prescribed, performing regular growth measurements. If poor growth is apparent, you want to perform a 24-hour diet recall and other nutritional assessments. And then preventing complications of crisis by getting them treated quickly. All right, reducing the risk of caregiver strain. The sickle cell disease is a chronic disease that's accompanied by life-threatening episodic crises, so this can put a very strain on the caregiver. So you want to help families deal with their feelings about the disease and its implications, exploring resources in the home and community to see if the parents are able to give medications, fluids, and provide adequate nutrition. You want to assess their knowledge of signs of infection, signs of a sickle cell crisis, and when to seek medical care for the child. And so these are all important that they know when these things are happening so that they can get prompt treatment for their child. You also want to refer families for genetic counseling, especially if they plan to have more kids, so that they will know about their risk of transmitting this disease to another child. You also want to refer the parents to support groups so that they can have contact with others with the disease, and sometimes that is beneficial and helpful. All right, evaluation. Some of your expected outcomes may include the client demonstrates no signs and symptoms of hypoxia, they deny dyspnea, they experience no complications of the sickle cell disease, including stroke or acute chest syndrome. They will demonstrate adequate nutrition by moist mucous membranes and a urine output of at least 0.5 milligrams per kilogram per hour. They will demonstrate no signs or symptoms of infection. They are current and up to date with all their recommended vaccines. They will report absence of pain at a tolerable level. Family and healthcare personnel promptly recognize and treat complications of the disease. Your pediatric clients will have normal growth and developmental milestones and meet those. Parents and other family members receive information to manage and understand the disease. They may also need referrals. The family demonstrates adequate knowledge of the disease and treatment regimens. So this is the end of the sickle cell disease content, and as always, if you have questions, let me know and I'll try to help clarify.